And this is an important thing that I really want to make sure everyone in the audience knows. This is what CD34 looks like in a big kind of juicy dermatofibroma, particularly like a large cellular dermatofibroma. If you do a CD34 stain, which of course we teach is CD34 negative in dermatofibroma, factor 13A positive. We'll talk about factor 13A in a second. But I think that one thing that can confuse people is that CD34 is negative in the middle of a dermatofibroma, but it tends to be strong at the periphery, stronger than the background dermis. Remember that CD34 is normally positive in dermal dendritic cells, and if you stain normal skin, there should be CD34 staining scattered throughout the dermis, like you see up here in the upper left corner. That's normal. If you don't have that, then your CD34 probably didn't work correctly. The 34 should look dirty in the dermis normally. So that's because these dendritic cells, what I don't fully understand what they are or what they do, but they live there in the dermis and they stain with CD34. I can tell you that much. I'm just a simple morphologist at heart, and I don't always understand the underlying cell biology and the deeper nuanced truths that more intelligent people than me will have to explain. But what I can tell you is that these cells, what they do is when a dermatofibroma grows, it pushes outward, and those CD34 positive cells get pushed out of the way, and they tend to pile up and accumulate along the periphery. I don't know if this is exactly how it happens, but in my mind, that's what I imagine happening, and it makes a nice memory tool to think of the DF expanding and pushing the CD34 out of the way, and they pile up along the edges like snow in front of a snowplow or something like that. And so it forms this kind of halo of darker CD34 staining at the periphery of a DF. And so this is totally normal and expected to see this in dermatofibroma. And when you've got a big sample like this, no problem, you can tell it's negative. But what happens if you got a shave biopsy at the top of this thing? You could see pretty much only the 34 positive halo and not see all the negative stuff down below. And if you're having a bad day, you could potentially get that confused or have concern for a DFSP. So that's why I don't routinely order stains on dermatofibromas unless it's something where I have a partial biopsy and morphologically is challenging. Some DFs have storiform pattern and thin spindle cells instead of plump spindle cells. And if I get a partial biopsy of one of those are the ones I often will do a CD34. And if it looks positive or patchy, I'll send it off for FISH to make sure it's not DFSP. But if I've got a nice sample and classic DF features, I don't really feel there's any need to do an immunostains in that setting. Now, my comfort level is probably a little different as a soft tissue trained dermatopathologist because I've seen lots and lots and lots of weird variants of DF, and so it makes me really comfortable. In fact, the very first case I ever signed out on my own in practice, on day one of practice, was actually an aneurysmal and cellular dermatofibroma. So I thought that was so fitting, and I felt so comfortable having done a fellowship in soft tissue and dermpath. I was like, this is what I prepared for. I can handle this case. And then, it progressively got more challenging from there. So I keep thinking one of these days dermpath will get easier, but 10 years in, and boy, it's still a struggle some days. So if you guys ever feel like that, you're not alone. All right, well, I really went off on off the deep end here, but I wanted you guys to know about the halo around the dermatofibroma. And yeah, particularly on a partial sample, if you get an area like this or a punch that goes down just and gets the edge like that, you can really have trouble. In the middle, this is a different stain from a different case with the red chromogen, but look, beautiful, nice, rich vascular network in the background. And it's okay, like I said, especially in big cellular or aneurysmal, large dermatofibromas, it's common to have a pretty robust vascular network. Sometimes they're staghorn, sometimes they're really small and plexiform, but don't worry about the vessels. The point is that the lesional spindle cells in between are dead negative in the middle of a big, juicy cellular or aneurysmal dermatofibroma. That halo is only out at the edge usually. All right. Now, because people do ask about it, and I know a lot of my colleagues like factor 13A, so no judgment. If you want to use it, it does usually stain dermatofibromas. But I think sometimes people have the conception that it should be like strong, diffuse wall-to-wall staining. And I basically never order factor 13A for spindle cell tumors, for dermatofibroma or any other, just because it's really non-specific. So I don't find it that useful personally. But if you do, go for it. I'm not going to judge you at all. If you do Vimentin, I will judge you, because Vimentin has absolutely no role in modern soft tissue spindle cell tumor pathology. In other organ systems, I have no right to judge, but I will tell you, for spindle cell tumors, it's completely worthless. And I'm happy to have conversations with people who feel otherwise. So that's the hill I've chosen to die on, is the Vimentin hill. But in any case, that aside, factor 13A is okay if you want to use it, in my opinion. But what you will see is scattered dendritic cells. Not every cell in the lesion is usually positive. It's usually these factor 13A dendritic cells they're factor 13A positive and CD34 negative, and they tend to be abundant and colonize the background of the dermatofibroma. But you're not going to see like a diffuse strong staining. Usually it's more this kind of patchy scattered dendritic staining. Okay. Also, I'd like to call your attention to the fact that smooth muscle actin is often positive in dermatofibroma. Patchy usually, but in some cases, particularly ones that are kind of more fascicular, I think that they have more of a myofibroblastic phenotype. And so because of that, they tend to stain with actin, oftentimes in that kind of tram track or train track pattern of parallel subplasma membrane staining that's kind of lighter and wispier and not as strong and rich and diffuse as like true smooth muscle actin staining in a smooth muscle tumor. But I do feel like sometimes if there's fascicular and some actin, that people have a tendency to want to call those smooth muscle tumors. And don't do that, okay? With practice morphologically, a true smooth muscle tumor should have abundant pink cytoplasm. It looks very different from fibroblastic or myofibroblastic proliferations, or including dermatofibroma, okay? And I do have a video on YouTube and Kiko about how to tell myofibroblasts and fibroblasts from smooth muscle. And so you can go, I've got a couple videos actually about that, but it can be done on H&E almost always, with rare exceptions. So they do look different. So don't let actin make you call something smooth muscle tumor that doesn't look like a smooth muscle tumor. All right, it's positive oftentimes in DFs. Don't be worried about that. In Desmond, I will point out, and this I think can be a little bit more bothersome, at least it was to me. I've seen a handful of Desmond positive dermatofibromas, including, I think they were mostly cellular dermatofibromas. Now, it may be that Desmond can be positive in run-of-the-mill conventional dermatofibromas. I just don't usually stain those, so I don't know. Maybe it is positive more often than I realize, just because I'm not looking. The ones that I tend to see with stains, either because I've done them or someone else has done the stains, tends to be the bigger cellular, more mitotically active, the more worrisome looking dermatofibromas are the ones that tend to get stains and sent in as a consult, or that I tend to see from colleagues who've worked them up. So, and I remember one particularly, and I sent it to Dr. Weiss actually, because it was on the eyebrow of a young girl and had Desmond, a lot of Desmond, and it had some necrosis. And I thought, oh my gosh, is it a rhabdo? And the myogenome was a little difficult to read, but I was worried, face of a child, maybe it's rhabdomyosarcoma. And she said, no, this is just a cellular DF that has Desmond expression. And as far as I know, everything's been fine with that child, years later even. And I've seen, since then, I've seen other examples of cellular DF that have Desmond expression. So it's not common in my experience, but it certainly can happen, and it's something to be aware of.